Okay, first of all, let me just say, it is just so wonderful. Generally, at the end of conferences, you're used to really 10% of the audience being around. And I think it is just so encouraging to see so many of you still with us, and even more online. I think there was overwhelming response for this meeting. Some 700 people wanted to come, and in the end, we limited it to 500. And as I said, it is just such a pleasure to see so many of you still with us at the end of quite a tiring 1.5 days. But of course, we have a stellar panel with us today. I'm very pleased to be chairing, or moderating rather, this second panel, although I cannot possibly outdo Professor Chi. For those of you who were here yesterday, you know that he is in a class of his own. Despite knowing nothing about the topic, he managed to pull off a stellar session, and I hope that I will be able to do even a fraction of what he is capable of achieving. Now, before we actually open the questions to the floor, I'm actually going to ask each of our panel members here a little bit about the problem we are discussing now, the enablers and the challenges in value-based healthcare, and to give some idea of how they feel and how they see the problem from their perspective. Now, first of all, I will start with, it's quite intimidating when you have to ask your own boss, right, to start off. But anyway, I'm going to ask my boss, Professor Kenneth Mark, to really talk about, in the Singapore context, we've been doing value-based healthcare now since, it's been a strategic thrust since 2016. And of course, the last 2 years, we've been very, very busy with COVID. But I would like to invite Professor Mark to give us his views as to what he feels about what has worked well, what has not worked as well, and what we need to be doing in this space. Professor Mark?
Thanks. Actually, I was going to take to heart what our MC, Hajit, had said, because he said that the moderator is going to answer all the questions with the assistance of the panel. So I was going to take a supporting role to you, Daphne. Value-based care is a burning platform for us here in Singapore. We've not necessarily said it so explicitly, but I think it's probably appropriate in this particular platform to actually say it in this way. We've seen the cost of care rise quite significantly, not necessarily with any significant added value when it comes to outcomes and what we think provides benefit for our patients. It's driven by many different factors. We all are aware of the aging demographic in Singapore, and with the aging demographic comes a high incidence of chronic disease, and with an increase in chronic disease comes an increase in utilization of healthcare services in Singapore. And it becomes more and more challenging then to make sure that we have the appropriate level of resourcing to meet the healthcare demands of our population. Costs of individual treatments continues to rise, particularly with the newer, more novel treatments that have made themselves available in Singapore. Our pharma industry do practice a variety of different ways of setting prices, and there's differential pricing that doesn't necessarily do us favors as well in Singapore. And we end up having to pay significantly more for treatments that otherwise might be cheaper in other countries. There's also, given perhaps the abundance of services that we have in Singapore, a certain complacency that sometimes sets in. And we're starting to see increased utilization of services which arguably may constitute inappropriate ordering of tests, of treatments, of medications. And there's a need really to think in terms of whether or not this is bringing value to our patients as well. But when I look at the impetus for driving change, I realize that this is not just the Ministry of Health identifying an issue, making it a burning platform and trying to drive this through. In fact, most of the work in value-based care has come in two directions. From the top, but a significant proportion of work has actually come from the ground. There has been a realization within hospitals that they do need to do their bit in constraining care. Individual clinicians have also become to realize that the care that is being practiced, sometimes in the community of specialists that they work in, has every potential of, in fact, running rampant with new treatments coming in. And the issue of cost effectiveness and clinical effectiveness has to be very carefully considered. It cannot be simply a decision made on the basis of which a sales rep from which company comes into your doors a couple of days before in your clinic. There has been a ground-up initiative, particularly in some of our hospitals, looking at value-based care, and really trying to see whether or not they can either improve or maintain clinical outcomes while at the same time see savings. And I think that's a very reasonable approach. And having these as ground-up initiatives means there's a significant amount of ownership of the issue. And I think that's important because then clinicians feel a sense of responsibility of wanting to do their bit, to practice an individual discipline of helping to constrain the cost of care for their individual patients. And when clinicians do so, that's very powerful. They see the benefit immediately for the person standing in front of them in the clinic, as opposed to in the ministry when we make policy decisions. We do this for the public, but there are no faces in front of us. So there's a certain sense of impersonal. It's really impersonal, but really when you have a person in front of you who really is going to benefit from the initiatives you take to save money for that patient while at the same time protecting outcomes, it means something. It means something very gratifying, and you know it makes sense for the patient in front of you. So I think it's very important that many of our activities should be ground up, but there's a need really to look at the overall infrastructure and the design of what we need to do at the systems level. And this is where the Ministry of Health has identified this as an important issue for us to do. Because larger decisions like whether or not treatment should be allowed in our system, whether treatments are too expensive, where arguably cost effectiveness cannot be demonstrated, in a system where risk pooling for funding and subsidies means that the entire public, the entire population takes on the burden for an individual who's receiving more and more expensive care. We really have to think about how we want to design our healthcare system to better support the needs of our population, not today, but 5 years later, 10 years later, 20 years later. And it does mean major decisions to be made to design the system in the right way, taking some pain where we are now to move forward in value-based care. So I don't think value-based care is a theoretical exercise for us. It's an exercise that has immediate meaning for our patients in front of us, but has significant impact on the healthcare system, how we will deliver care, and how we will benefit our patients, our population in the many years ahead. If we don't get it right now, we set ourselves for a fall many years later when the cost of care becomes so exorbitant that it becomes even difficult to deliver the appropriate level of care that we think is right for our people. It has to be a co-owned journey with clinicians, hospitals, and the entire healthcare system in MOH on board, and we need then also to base our decision-making with one key stakeholder right in front of us in the midst of a discussion, and it is what makes sense for our patients. And I think that probably would be the way we need to go on this.
Thank you, DMS. I'm just going to move on to Sarah. Sarah, I just want, for those of you who are not familiar with the PharmAC, which is the agency that looks into pharmaceutical supplies for Australia, New Zealand, it's very much admired for the fact that you're able to provide for the medications for your country while keeping it at a very low budget increase for drugs. Now, we are in an environment where our drug costs are growing by around 14 to 15% per year. This was pre-COVID, and we're waiting for the numbers to stabilize now that hopefully the worst of COVID is over. But how do you do this? How do you provide quality medications for your population while ensuring that you don't bust the budget?
It's an ongoing challenge. I think compared to other countries, we probably do get access to medicines later. There's no doubt that we have a small population. Many companies do find our way of working quite challenging. They know it's a tough market to get into, but they know that we do run a good process that's very evidence-based. We have a fixed budget. We want to deliver good decisions to the population, but with having that fixed budget, it does provide some challenges. And it has been difficult, particularly over the last few years. I think patient expectations have changed considerably, and they see countries overseas having access to medicines ahead of us, and they don't want to wait. They want to have access to these medicines. But then it becomes more of a political issue because it's the government decides what our budget is. we decide how that money is spent. The government can't tell us which medicines to fund. We run a process which I think most people recognise as a fair and a robust process. But at the end of the day, as you said, there's always going to be more demand. There are so many new therapeutics, diagnostics coming onto the market. I think every country is going to be faced with the dilemma as how do you manage this when there are so many other competing priorities in health as well. We were talking last night about workforce issues, all the new services that are coming, new hospitals being built. And the other big thing, I guess, from our point of view is that focus on prevention. There's a lot of focus on the high-end, new, expensive treatments at the end of the pathway, but actually would we be better spending more money in prevention? And I think, we've seen that with COVID, the efforts that went into public health with vaccination has delivered good outcomes for many countries. And I think that's something we probably need to be looking at, how we deliver healthcare in the future, that there needs to be more of a focus in the primary care end rather than the bottom of the cliff in the hospitals with expensive high-end treatment. So yes, we have got a system, but it's not without its challenges. So I wouldn't want anyone to think that it's easy or that we're not in the firing line a lot for access to new medicines. It is an ongoing challenge.
Thank you. Okay, Erwin, there's already a question in I'm trying to find it because my iPad has just chosen to lock me out. So now there's a question now on really the patient perspective. And the question is, how can benefit that is valued by patients and providers but are not typically captured in questionnaires and scores be taken into account when we're doing value-based healthcare, such as relationships, trust, and the preference for non-medication or non-procedures? How do we sort of bring this on board and get those inputs that we don't typically address during a typical clinical consultation?
It's a good question, and you should go to my talk that I just gave about an hour ago. It's recorded, you can watch it. That in the end is the subjective question of what is value. When we talk about value-based healthcare, it's easy to use health economics to put a dollar amount on everything, including quality of life, and work out costs in terms of dollars. But as you say, what matters to the patient is just not the costs, but other things like relationships, feelings of loss, loneliness, and things that are intangible. So how would you measure that? So like I was presenting in my session before, there are ways to do it. You ask the question is one way, and you document it. So we have a question that we ask every patient, what matters to you? We find it, and at every single journey as they go through the health system, and we try to address that. So, like I was sharing before, for some patients, it's someone looking after the dog, someone holding a hand. And so it's more than just getting the best treatment, curing them of the disease. It's other things as well. And I think that's, in the end, I think we can all understand that because we've all been patients. We know that it's kind of like using an analogy of flying around in the airline industry. You want to go from A to B, like I'm flying here from Melbourne to Singapore. I want to get here, but it's not just about getting here. You better get me here on time. You better give me the service I want. It better be a comfortable flight. You know what I mean? Like it's not just about getting A to B. Similarly, in healthcare, it's easy to just say, well, I got you from A to B. I treated you for your disease. Why aren't you happy? There might be other things. So it's about capturing that value. And as some other presenters have brought up, the formula that we've been using to do cost-effective analysis, it may not take into account some of those other things. And in the end, it's a difficult calculation, to be honest. We were just talking to Sarah about the question of ethics as well. What ethical framework would you use to make sure your decisions are ethical when it comes to saying yes to some people but saying no to others? And the prevailing framework is consequentialism, it's utilitarianism, right? The greater good, the majority gets treated. But the danger is you do have minority people who miss out, and we just need to make sure, and Sarah gave a talk yesterday, measuring that, vulnerable groups like the Maori, the indigenous population, are not missing out, as you make decisions.
Thank you. Thank you. So Zili, one for you. Obviously the buzzword nowadays is healthier SG, and the GPs are going to be, a very, very critical part of that. And I think I can't remember the last time that, the GPs were so central to healthcare transformation in Singapore. So how do you see this whole piece of value-based healthcare? What do you see as the role of GPs?
Actually, if you go back, GPs, family doctors, they've been around for a very long time. Like your father, he's done a great job, right? Right. And we all know about George and his great contribution. So, and the thing is, we are actually the silent majority in the background. We just do our bit and we carry on. And I'll just share it with my students. Just a couple of days ago that, in the past, the GP would wake up in the morning, he would go and see his patients, do house calls in the morning, and then they get back to their practice, and then they start seeing their patients in their practice, say about mid-morning, late morning, and then so on, and they would do another house call in the nighttime for their vulnerable patients. So I think GPs have been around for a long time. So the question is, I think family medicine has evolved over the past 20, 30 years, and we've seen it change to becoming more corporatized. And now that we have Healthier SG, actually it is not just Healthier SG, but over the past few years there have been many changes to our healthcare system, such as CHAS, the Community Health Assist Scheme, which was very welcome. Things like Pioneer Generation, Medurka, and so on. And these actually gave us confidence to press on, and subsequent to that, past 3 years, we've gone through COVID. And I think I must give a clap to all our GP colleagues, because they stepped up. They've proven themselves, they can deliver the goods. And I think if we go by the chatter amongst our colleagues in social media and so on, you find that there's quiet optimism. I can say that. There's quiet optimism, some not so quiet. But I think assuming we can get the details right, I feel that Healthy SG will take off very well. I mean, just last week we had the white paper shared with us, and in fact I brought a cutting from the newspaper. And actually it's very interesting because, they support, but of course, like all people, they have concerns, but these concerns can be ironed out. It's all about the details. The devil's in the details. And if we get the right support, I'm sure the sky's the limit to what we can do. And I think once there's more clarity to how things will progress, I'm quite confident that the take-up rate will be very good, both from the profession side as well as from the community.
Definitely, I hope you don't mind. Just going to respond to Zili. Zili, I think we underappreciate what family physicians can do in value-based care and potentially even Healthy SG as well. One of the key elements for Healthy SG that we will be debating in Parliament next week is really what we define as the relationship between the patient and his family physician. And we want to establish this trusted long-term relationship. Enrollment helps to sort of bring that longer-term relationship into the fore. But what most people miss out is that relationship is a trusted relationship, because over time, it's not just to facilitate chronic disease management, but over time, with that interaction, the degree of trust builds up, the GP becomes the person that you turn to for the difficult decisions in life. as well. And a lot of times we emphasize specialist care. Yes, specialist care may be a driver for a lot of healthcare costs. But in the conversations when it comes to appropriateness of care, which is an important element when it comes to defining value, we often dismiss the role that a GP can play. And many of our patients, as a surgeon, I've seen this, I talk to my patient about what I think is in the best interest of my patient, whether to go for surgery or not, the extent of surgery I do. And many of my patients then say, thank you very much, I need time to think. I want to go back and talk to my GP. So that potential for the GP to play a role in decision-making to help a patient to understand what appropriateness of care is that helps to define value, I think it's an important consideration. Therefore, the tragedy to me is that we don't involve as much family physicians in this whole process of value-based care as we potentially can. It's still an early conversation. We've got polyclinics involved now. But I think to bring the larger primary care fraternity into a better understanding of value-based care and the role they can play, particularly in advising patients on what constitutes appropriate care, I think is something that we haven't really fulfilled that potential or really grasped the extent of that potential.
Yeah, I totally agree with and I feel for what you've just said, because I was just sharing with in my session. Today is my 30th year in my practice in Choa Chu Kang. So we started our practice 30 years ago today, and many of those patients actually we've seen for those 30 years, and they do come back because they have doubt, or they have some clarification that they want, and so on. And the continuity is what makes it possible. And that you're right, is the relationship. So at the end of the day, we want to build on that, and I'm quite sure our colleagues, our GP colleagues, we be very supportive of this. Yeah.
Okay, next question I'm going to ask to both DMS as well as to Erwin. And actually, there are two questions which I'm going to combine to one. So the question is, we are in an environment right now of manpower shortage and also IT systems that are evolving. So how do you deliver, value-based care when there are shortages in manpower and suboptimal IT systems? So I'm going to, whether DMS or Erwin would like to.
I guess, Erwin, you talk about the Australian experience, I'll talk about the local experience, shall we? It's indeed challenging, and we do work in a system that is currently in flux. And I think all of us here who are working in public healthcare institutions know we've changed some of our electronic medical records in some of our hospitals. We've had downtimes. People get frustrated by the extra work they have to do, learning a new system. They spend twice as long in a consultation as they did before. But that journey wasn't just related to IT. We had safety checklists before that. More people spend time on a checklist than they do actually sometimes talking to a patient. And that builds up. And there's a lot of administrative overlay in the work that we're doing now. And coupled, of course, with the manpower challenges that we perennially face, perhaps now it comes to the fore because of the extraordinary effort that people have taken with COVID and the amount of fatigue that actually the workforce has, these issues will come to the fore. But it doesn't stop us in our individual clinical decision with our patients, still asking ourselves what is in the best interest of our patient. And irrespective of where we are, some of these decisions still take the fore. It still allows us then to decide whether or not we can make appropriate decisions for our patients. And that should still continue, irrespective of the resource challenges we have. We're working to try and improve the system. I don't guarantee that at the end of the day, we'll avoid this decision-making still about having to make choices about medicines to give, treatments to give, and asking ourselves what provides value for our patients. That would still be there. We hope, obviously, when the system is more optimized, that decision is easier. I'm not sure that will be. But I think irrespective of the challenges we have, we still have to look at that perspective.
Thank you. Thanks, Kenneth. I actually had dinner with Kenneth last night, and I was expecting him to finish up the last 15 minutes with his answer based on my conversation with him. No, I'm only kidding. Look, the issue of workforce, digital health, and value-based healthcare are inextricably linked. They're all they all need to be working together. What I mean is, with the workforce, as Kenneth has very eloquently summarized, it's the same situation around the world, really. right? There's a global workforce shortages of nurses, but also of doctors and allied health professionals. There's burnout. There is all sorts of issues of people leaving the profession, lack of global now movement of professionals between countries to kind of fill gaps. So that's a main issue, and really part of the solution is redesigning the health workforce so that they are better utilized. So this is the whole value question, really, is ensuring that doctors are doing what only doctors can do, nurses are only doing what nurses need to do, and then create alternative workforces that kind of do all the kind of things that doctors and nurses and other professionals don't have to do. And you kind of need to do this anyway, because there are not enough nurses to go around. So it's about, no question about it. At the moment, a lot of countries are now trying to train more nurses, create more incentives, but I think the workforce needs to change. We were just discussing yesterday about, one of the posters was about speech therapists and occupational therapists sharing a workload and crossing boundaries between the scopes of practice. And we need to reform how we train our clinicians so that they are more generalists, because at the moment they're super specialists, and there's nothing wrong with that, but they need to be able to also cover for one another. So, lots of that has to be done, but that can only be really optimized with the help of virtual care and technologies, right? So there won't be enough doctors to go around, so we need to use telemedicine, telehealth, virtual care to be able to reach out to places that don't have enough of the clinicians on the ground. We need to, and this is where the value comes into, you need to ensure that when you invest in technologies, it's recognized that they are a tool to help you do your job. They're not the solution for everything, but something that has to be used wisely. A great example is surgical robots. They're all fancy and all our surgeons want, but some of the evidence would suggest that maybe the outcomes are about the same as normal surgery. So you need to be careful about investing in things, the same analysis that you would do in terms of the technology. So I think they're all linked, and once we get the workforce design right, supported by the technology, you will see low-value processes removed and reduce waste.
Yeah, there's great value to simplifying things. And I think sometimes in our own work processes, certainly in our own public hospitals, we have very complicated workflows. And sometimes I think it's because the higher IQ we have, the more complicated the things we do. And there's great value in just making things much simpler than they are. And if we focus people on the important decision-making they have to do and help them not to be distracted by other issues, I think that does help in making the correct and appropriate decisions as well. And we need to also, in the midst of introducing change, improving things in hospitals, increase visibility. I think we need our clinicians more conscious about the impact and effect of decisions that they make in terms of outcomes, in terms of costs, so that the decisions they make now are just not a reflex one. They really are thinking through what makes sense for their patients.
Thanks. Okay, next question for you, Sarah. Two questions, in fact. The one question relates to allied health. The question is, how can allied health professionals do more in the value-based healthcare space? Right now, the last few years, we've been quite focused on, how doctors are adding to costs and, how the things they do contribute to value. But what about allied health? And the second question is more specific in the New Zealand context. Because of the policies that New Zealand has, have you seen, certain manufacturers not enter the New Zealand market, and how has that adversely affected the health of the population?
So yeah, on the first question, I'm not sure if I can really speak for allied health as a whole, but certainly from our perspective, and particularly over COVID, the role of the pharmacist has really expanded. Certainly from using our community pharmacists for vaccination, and in fact, we made our COVID antivirals pharmacy dispensing so that people were actually able to access them over the counter in New Zealand, which was quite a big change, but actually has gone really well. So I think particularly at the pharmacing level and also from a nursing point of view, increased nurse prescribing, that's certainly grown in New Zealand over the last few years, nurse endoscopy, areas like that. So that's probably as much as I can comment on general allied health role. The second question's a bit easier for me. So it's a common point that's raised that people won't come to New Zealand because it's too difficult and it's too small population. We actually find the opposite happens, that actually because of the way our systems run, if a company is successful in one of our competitive processes, they get the whole market for 3 years. So they're guaranteed the whole market. So that is quite an advantage for companies. They don't have to have staff on the ground trying to sell their product. They know exactly what the volumes are going to be. They know what the price is going to be. So actually, that can be quite attractive for a supplier. Where we do have issues is probably with some of the rare disorders medicines, because our population is quite small. For a company to set up in New Zealand is quite expensive, and they don't particularly want to go through a whole registration process and then have to go through the funding process. So we've made some exceptions for the very small markets where we will assess them in parallel with the registration. So we've tried to be sort of flexible, particularly when there's really small populations of patients, so patients don't miss out, because that is quite important. But as far as the general suppliers, they often threaten to leave, but they don't. Or if they do, they come back. We've had that with a couple of companies. But from a supplier point of view, it's actually quite a neat and tidy market if they're successful, so they actually quite like that.
Thank you. I'm going to ask Erwin something, and then after that, Zili. Now, one of earlier on we were talking about the fact that this came up because of the issue of colonoscopy as a screening tool for population health, and we mentioned that a colonoscopy at full prices is about $2,000 in the Singapore market, but you mentioned that it's only $300 or so in Australia, and Australia is not exactly a low-cost market. So how does this happen?
I mean, so first thing to say is that the costs, obviously, to calculate cost per unit in terms of procedures, there's a lot of factors involved, right? It's the actual instruments, the consumables, the time for the proceduralists, all of those things come into play, and the support systems. But if you add it all up, we do use, we do have high volume endoscopy centers. We do use alternative workforce like nurses to do endoscopy, cystoscopies as well. We do allow that. And so that reduces the cost, I think. And our system is such that if you go to our public hospital, you don't get charged anyway. And in our private hospitals, it's actually not that expensive because it's something that's done. We do a lot of public and private screening. But just to your point about allied health professionals, though, I think just to add to what Sarah has said, I mean, there are a huge pool of talent that are underutilized. So, and people have been trying to break that barrier. So, where I was from before I joined St. Vincent's, we were trying to upskill our physiotherapists in our emergency departments to do all the fractures and to do plasters, musculoskeletal injuries without needing for doctors to be involved. And similarly with podiatrists and other professions, the irony is that the barriers didn't come from the individuals, it came from the Australian Physiotherapy Association, because they were worried that people were going beyond the scope, came from the regulator. So APRA, which is like the physiotherapy board, refused to register those physios because they were afraid that they were doing things that were outside the scope. So, there are a lot of barriers really to wanting to do innovative reform in health. A lot of it's to do with legal, regulatory frameworks that kind of stymie you. A lot of it's to do with the unions as well and the professional associations, which come and kind of block you. And then the AMAs hasn't been helpful because they're worried that other professions are doing what doctors would do. And, the argument would be quality and safety, which is on one hand fair enough, but on the other hand, you can deal with that. So,
yeah.
But I think that is a big population of
So I think that was the whole point of why it's so important to measure outcomes and the cost, because really if, and we talked about the project where they had the OTs and the PTs, sort of cross-covering each other, and even as we talk about care moving from super specialists to GPs, or doctor care moving to nurses or pharmacists. I mean, if they can really produce the same outcomes and in that sense, provide better value in terms of outcomes divided by cost, then I suppose that's something to think about. But as you mentioned, there are many, many barriers to that. Over to Zili. The question is, as we talk about healthier SG and the new role of the GPs, how do you see yourselves integrating more and working more closely with the community?
I think going forward, for those of us who have actually already been in the community for a while, we already integrated. The question is, how do we fit into perhaps the public health institutions and the clusters, to be able to provide that care? I think the key to it is actually to be integrated with through the primary care networks. So the primary care networks provides that support so that we are equipped to provide the necessary set of services to our community. And then, of course, the primary care networks act as a conduit between the practice as well as the clusters which are going to be heading this. So I think going forward, in fact, right now, I think the PCNs are going to be instrumental in being able to deliver that. And of course, I think without the support of the clusters, I think it would be almost impossible, very difficult to be able to provide the suite of services that we would be able to provide for our patients. So I think those are the two things. But I think for most of us who are actually already in the community, we already do this, but being plugged in gives us a lot of help to be able to deliver the care.
Thank you. Okay, we only have 3 minutes left, so I only have time for one more question, and I'll open it to all 4 members of the floor, of the panel, sorry. And the question is, the patients want what they perceive to be the best quality care, regardless of cost and regardless of value. How do we change this mindset? Perhaps I will ask the entire panel to give their views.
Maybe I shouldn't answer first.
Okay, all right.
We'll let the others give it a
Okay,
go.
all right. Would any of you like to start? Okay, maybe
I'll say something. I don't think that we need to change that, because I don't think that that's ever going to change. So if it's your family member, your loved one, your child, your mother, your sibling with a disease, you want the best for them no matter what. So that's not going to change. It's not as if you're going to go, you know what, I'll let my daughter die to save this other person's daughter. They're never going to say that, because by definition, that's your role as a family member to look after your family. So I think that's not their role. Their role is really to advocate for the family member, to save them, to look after them. I think on top of that, though, society has to come up with some rules around how to manage society. I don't know that it'll be fair to leave it to the individual patients or their families. Do you know what I mean? Yeah.
So absolutely right. I mean, basically, you want the best for your patient, your family, your patient, but patients come in all shapes and sizes. So decisions and what they want may actually be different. So someone who is at the end of life, you may not want to, or they may choose not to be intubated, but is someone who is young, who has an acute episode, then you'd want to go all out to save that life. So I think a good relationship with your family doctor or your physician who's in charge of your case, I think that is very important, so that you can make that informed decision.
A lot of decision making we make is not just clinical. There's a significant social overlay. Sometimes when we've got patients who come in very acutely, with a medical crisis or surgical crisis, and a harsh decision has been made whether to escalate care or in fact go a very different trajectory, reflecting that care might be futile. It's a very difficult conversation to make to parents, to family members, because sometimes there's guilt, about a lack of support previously, and perhaps that may have led to the situation the patient's in now. A frustration, anger, and a demand then that something has to be done amidst all that anger is a very common scene that we see when it comes to doctor-patient interactions. But I think it's important for us to also frame that sort of conversation correctly. Because as clinicians, as we mull over the treatment choices that we want to present to our patients, I think it's important we present the right list of choices. And the choices should be curated to what we think really brings value or benefits a patient. And when we talk in terms of what is best for the patient, it's in what is in the best interest of the patient. Not necessarily what gives the best outcome, nor necessarily what is the best in terms of cost. But it has to be a considered decision weighing all these factors together. I think we bear a responsibility of being transparent with our patients to make sure that, we share both the good and bad, the impact of a decision that's made. So it's not the issue of presenting whether a patient should go for surgery, should go for chemotherapy, but to help a patient understand the consequences of a decision that's made in terms of the likely outcomes or lack thereof, or the possible complications and risks of harm, and the likely cost impact it is. And then that decision is a much more nuanced one, a more careful one, a more holistic one. I don't necessarily think we need to take away that right for a patient to make a decision, but I think it's important that we are transparent and bring all the considerations in, so a patient's consent is really an informed consent, and he makes the right decisions. And the right decisions are not necessarily that we go with best-in-class drugs, but what we think would be in the best interest of that patient.
I probably can't add a lot to what's been said, but I totally agree. We don't want to be changing the mindset. I think everybody should be able to advocate for the best treatment. There's probably a managing of expectations across society as to what each society can provide, but at an individual level, every patient should be, advocating for what they think is the best treatment for themselves and their family. So, totally agree.
Thank you. There were a lot of questions, so I'm afraid we couldn't go through all of them, but I tried to answer, to bring them up in the order in which they were submitted. So I think it just leaves me to thank the panel for a very interesting discussion. I think it was very rich, and I'm sure that we all benefited from it. Thank you.